What we're doing is that we're cutting off the stomach right here along this line and turning it from a large storage tank into a thin sleeve. And because of that, we are able to take out this portion of the stomach that I was talking about in the podcast called the fundus. And that fundus is the source of that hungry hormone called ghrelin. And that decreases your appetite, but also causes a lot of other hormonal shifts in the body that shift your body over to fat burning rather than fat storing. This is a high pressure system because you're going from this big, large tank to this thin little sleeve here. One of the risks of the surgery is reflux, where the acid contents of the stomach, if you eat too much, can actually pop back up into the esophagus and give you pretty bad reflux pain. Hello, everyone. Welcome to the first video presentation of Bari Chat with Dr. Sehat. My name is Dr. AJ Sad, a bariatric and foregut surgeon, and I'm excited to share this content with you to accompany the third episode of our podcast. I just wanted to visually show you the surgeries that I was talking about earlier because a picture is worth 1,000 words. So let's get started. So the first surgery that we were talking about in the podcast is the sleeve gastrectomy. This is the most common and popular surgery, bariatric surgery in the United States and worldwide. So what we start out here is with, this is the stomach. This is your esophagus coming down, going down into what's called your pylorus, which acts as the valve that closes off the rest of the stomach with the first portion of your small intestine, which is also known as the duodenum. So when we do a sleeve gastrectomy, what we're doing is that we're cutting off the stomach right here along this line and turning it from a large storage tank into a thin sleeve. And because of that, we are able to take out this portion of the stomach that I was talking about in the podcast called the fundus. And that fundus is the source of that hungry hormone called ghrelin, or ghrelin, as I remembered it in med school. And that decreases your appetite, but also causes a lot of other hormonal shifts in the body that shift your body over to fat burning rather than fat storing. So as I was mentioning, this is a high pressure system because you're going from this big, large tank to this thin little sleeve here. And because of that, one of the risks of the surgery is reflux, where the acid contents of the stomach, if you eat too much, can actually pop back up into the esophagus and give you pretty bad reflux pain. It gets so bad enough that we'd have to convert you to a bypass where we make that small little pouch here. As I mentioned, you can expect a 50 to 60% excess weight loss with this surgery. So if that means if you're 100 pounds overweight, you're looking at about a 50 to 60 pound weight loss. So moving on to the next surgery, that's going to be the classic Roux-en-Y gastric bypass. And here I've already drawn it out for you on my whiteboard. So what happens is that previous stomach that you have, nothing is getting removed like it was with the sleeve gastrectomy. Your stomach still remains in place. It's just we're going to create a new stomach for you. So we staple off the stomach here to make this small little pouch about the size of a hard-boiled egg. And this becomes your new small neostomach. However, the neostomach needs a limb so that the food that you eat coming down from your esophagus is able to go down to the rest of your body. So what we do is we bring up a loop of small intestine and connect it to this pouch. And this becomes your new food pipe, also known as the Roux limb. The way I remember this is I'm originally from East Texas, and we got a lot of Cajun culture and Louisiana influence, and I grew up eating a lot of gumbo. And to make gumbo, for anyone who knows, you need to start out with a good roux. And so that's how I remember this, is that the roux is like the gumbo and the roux is the food. So the Roux limb is the food pipe. But we can't stop there because we need the digestive juices that you have to also meet with this food pipe so that you can actually digest your food. So just as before, this was the pylorus, this is the duodenum. So we take that limb and bring it up and over and make this new connection down here. And that's called your JJ, or jejunostomy. All that means is you're taking this limb of intestine, and connecting those two together. So effectively now what you've created is a new small stomach, a food pipe called the Roux limb coming all the way down here where this is your food, And then you have another pipe over here carrying your pancreatic and your bile acids and those digestive juices. And then that is effectively referred to as the biliopancreatic limb or the BP limb. And those two meet over here. And that's downstream is where the food and digestive juices mixes into what's known as the common channel. So with this surgery, you can expect a 60 to 70% excess weight loss. And the bypass part of this gastric bypass is this limb of intestine that's bypassed over here, where none of this limb of intestine is seeing food. It's only seeing the pancreatic and gastric juices. Very good weight loss with this surgery, one of the most studied weight loss surgeries that we have, and also very good diabetes remission with this kind of surgery. To the point, as I mentioned before, that your diabetes remissions basically begins the first day, the second day after surgery, far before you get your weight loss. Um, and if at any point, you lost enough weight, or you so if so desired to return to your normal anatomy because we didn't take anything out with the Roux-en-Y gastric bypass, we can always put you back together. The risks of this surgery, besides the leak here at the staple lines, anywhere you have a connection, there's leaks and bleeds. But also here at this new connection, this big black dot, that is supposed to represent a marginal ulcer. So what that means is that this piece of intestine has never seen gastric acid before. So it can develop an ulcer here. It doesn't have that protective mechanism like the way your stomach does. To help decrease that risk, one of the things that we do is after the surgery, we put you on an acid blocker for at least 6 months. The other thing that we also advise for all patients is that absolutely no smoking, either before, during, or after the surgery, because that increases your risk of developing this marginal ulcer. Because one of the side effects of smoking is constricting the blood vessels. And when you constrict the blood vessels, they can't feed this new connection, and thus you get an ulcer. We also tell patients not to take any NSAIDs, meaning ibuprofen, Aleve, of the NSAID category, because what that does is it decreases that mucus protective barrier here and thus increases your risk of developing an ulcer. You can also develop a stricture up here that would require another procedure to help dilate that. And if the stricture or the ulcer, if they can get bad enough, would need another surgery of what's a revision of your gastric bypass, where we cut out that piece and then put you back together a new gastric bypass connection. Now, as you can see, the other risk is called an internal hernia, and this is a 2D image, but if you can imagine that this loop of intestine is coming out of the screen, connecting back up here, there's this dead space that forms behind it. That's just, we can't do anything about that. That's part of the anatomy of how this connects up here. That dead space is going to form. So most surgeons, what they do is they'll suture that space down close to help prevent the internal hernia. However, as you lose weight, that space, because all that fat you're losing, opens back up, and you can always get an internal hernia afterwards, which is why we counsel our patients that you need to call us if you're having lots of abdominal pain or chronic abdominal pain, nausea, vomiting, not able to pass gas, or have a bowel movement. You need to come see us, and we need to fix it, as it can be a surgical emergency. And that's pretty much it for the gastric bypass. So some patients, they don't like the idea of having these two new connections. So is there a middle ground between the two? Which there is, which we'll talk about in the next surgery. So that's going to be the one anastomosis gastric bypass, or the OEGB, or sometimes commonly called the mini gastric bypass. So what you're doing here is you're creating this almost sleeve-like pouch. However, it's not a sleeve in the sense that anything is being removed. You're just making a much longer gastric pouch, like you did in the gastric bypass. Instead of cutting the intestine, though, into two pieces that we'd have to cut back together, what you do is you just bring one loop of intestine all the way up to this pouch, and you create that new connection right there. So what this means is that food goes down your esophagus into your new long gastric pouch and straight down into the intestine here. And then in terms of your bile acids and digestive juices, those are still coming up and around through here, through the duodenum, and then looping up and dropping back down. And the goal is that by creating this connection like this, where gravity is helping pull this fluid down, that none of this bile acid goes up into your pouch and falls down here and mixes with the food that you eat into your common limb. Now, that's theoretically, but one of the risks of this surgery is called bile reflux, where as this bile is making around this corner, instead of dropping straight down like it's supposed to, it can come up into the gastric pouch. And that can give you the same kind of reflux kind of pain. Lower marginal ulcer risk and a lower internal hernia risk. With this procedure, you're looking at about a 65 to 75% excess weight loss and a little bit better diabetes resolution than the Roux-en-Y gastric bypass alone. Now, what if you want something the most extreme surgery, or you're a patient whose BMI is greater than 50? Well, we have a surgery for you too. And you have the option of whether or not you would like one connection or two connections. So those are the duodenal switch, or also known as a traditional duodenal switch, and the SADI, the single anastomosis duodenal ileostomy. Um, so with both of these procedures, they start out with the standard sleeve gastrectomy. Actually, when this procedure was first theorized and created, it was talked about as being a two-stage procedure where you would get your sleeve gastrectomy first, lose a little bit more weight, and once you're at a healthier weight, come back and complete the procedure. It can also be done in one stage as well. It's at your surgeon's discretion of how to do that. But as I mentioned, you're going to start off with a sleeve gastrectomy. However, in this procedure, we're going to go past the pylorus, that gateway that I talked about before, and make a cut there. So there's a staple line over here in the first part of your small intestine, the duodenum, and the sleeve portion has the pylorus included in it. Now, just like with the gastric bypass and the duodenal switch, you're going to bring a loop of intestine up and make a new connection right here so that food can come from your esophagus down into the sleeve, past the pylorus into the small intestine. So you can think of this as the roux limb, and then over here, where that duodenum that you stapled off, this limb carries your pancreatic and bile acid juices, and those go all the way down, and you make a new small connection over here, so that your common channel, the channel where the food and the digestive juices are mixing, is right here. And none of this is drawn to scale or size. This is just a visual representation. But what I did was try to show you guys that the common channel for a duodenal switch is very short. So here, what you're seeing is the end of the small intestine and the beginning of your large intestine or colon. Specifically, this is where your appendix and your cecum. So this channel is very short. So because of that, you minimize your absorption, and this is why this procedure has the highest rate of weight loss, but it also has the highest rate of vitamin deficiencies. So, with all our bariatric procedures, we have the patients take bariatric multivitamins afterwards, but it's even more important with this procedure that not only are they taking their bariatric multivitamins, but they're also taking the fat soluble vitamins as well, vitamins A, D, E, and K. Because of this such short limb, one of the other complications is diarrhea, because you're not absorbing a lot of that nutrients, a lot of that food, and also protein malabsorption. So you really need to be aggressive with your protein intake. With this procedure, you can expect 80 to 90% excess weight loss, so really good, durable weight loss, but it does come at a price of needing to be reliable with taking your bariatric multivitamins afterwards. Anywhere there's a staple line, always a risk of bleed or a leak. Less risk of that marginal ulcer I was talking about here, because that pylorus separates this small intestine from the rest of your stomach, so that it doesn't really interact with the acid, and really not an issue with reflux from this standpoint. But because you have the sleeve gastrectomy, you are at a higher risk for developing reflux afterwards. So what if, again, you didn't want the two connections, you just wanted one, but you still wanted all that weight loss? Well, that's the next picture over here on the right. That was the SADI that I was talking about. So start off the same way. You do the sleeve gastrectomy. You cut off after the pylorus, so you have this stump of duodenum up here. But instead of bringing up one loop and making two connections, what you do is, just like the OHEB, you bring up one loop of intestine and make one connection right here. So what that means is food is coming from your esophagus into your sleeve after the pylorus directly down into this one channel. And then your bile acid loop is coming around over here and coming up and around and going down. And this is where the food and the juices are mixing and going down. Less of an internal hernia risk with this. And then, unlike the OAGB, because we have the pylorus here acting as a gateway, not really an issue with bile reflux as the bile goes next to here. That's what's it's protecting the stomach from interacting with that bile. Still excellent weight loss. Still need to be aggressive taking your bariatric multivitamins and A, D, E, and K. And you'll be getting lifelong labs, and we'll be checking on you aggressively. So I hope this helped clear up everything I was talking about in the podcast in terms of the surgeries. And, I'm a visual learner. So for all the visual learners out there, I hope this helped you out. As mentioned before, please like, review, and share. If you have any questions, don't hesitate to email me at drajsehat@gmail.com and follow me on my social media for more information. Until next time, this is Bari Chat with Dr. Sehat. Take care.